Hi everyone, this is Antoinette Bhattacharya from the DHIS team. Thanks so much for making time to listen to this session. In this session, I'm going to highlight the work done through the Gombe State MNH Partnership on strengthening the quality of routine data in primary health facilities. As a brief background, I think we all can agree that improving the quality of facility-based care for women and newborns is one of the most effective strategies we have to reduce mortality and morbidity. From 2016 to 2019, the Gombe State Primary Healthcare Development Agency led a maternal and newborn health partnership to increase the access, use, and quality of MNH services. And as part of those efforts to improve MNH services, the agency identified strengthening the quality of routine data as a priority activity. The reason why we focus on routine data is that accurate data are essential for effective monitoring of service delivery, and routine data has a really important role to play in this. With routine data, we can monitor and manage at all levels of the health system, and it's available at a frequency and level of disaggregation that we don't necessarily find in other data sources, such as household surveys. The reason why we concentrate on data quality is that as much as we would like to use routine data for decision making, we're often concerned about the completeness, consistency, and validity of routine data. For the rest of this presentation, I'm going to take you through an overall study question that we were trying to answer, which is, what is the quality of routine health data in Gombe State for monitoring priority maternal and newborn health indicators? And to answer this overall question, we had two sub-questions. First was, well, what are the priority MNH indicators that are available in Gombe for monitoring? And the second question was, what changes in data quality were observed following focused activities to strengthen MNH facility data? While I will highlight the methods, results, and key messages in this presentation, the full details are available in the two articles that are shown here, which are included in the additional resources folders that will be shared with you for the upcoming dissemination meetings. So to address the first question, which priority MNH indicators are available for monitoring Gombe State? We map the priority indicators from the strategy documents for ending preventable maternal mortality and the Every Newborn Action Plan to the data that was available in the 2013 version of the Nigeria HMIS. We checked to see which of these indicators were captured in the facility registers and in the facility's monthly summary report forms. To address the second question of what changes in data quality were observed following focused activities to strengthen MNH facility data, we used a before and after study design to compare an intensive period of data quality strengthening activities starting approximately in April 2017 through the end of 2018, and compared it with a similar 21-month early period from July 2015 through March 2017. We conducted a data quality assessment using data from approximately 500 facilities offering antenatal, postnatal care, and labor and delivery services. The data quality assessment is based on guidance from the World Health Organization Data Quality Review Toolkit, which is pictured here in 3 separate booklets. On the right-hand side, you will see 3 dimensions that we assessed and the 9 data quality metrics where we quantified different aspects of data quality. For the dimension of completeness and timeliness, we assess if the routine data are available and submitted on time. For the dimension of internal consistency, we assessed if the routine data contain values that are logical, plausible, and relatively consistent with each other. And for the dimension of external consistency, we assessed if the routine data tended to agree with external data sources, such as household surveys. To highlight a few of the data quality strengthening activities that IDEA supported, IDEA supported 4 data quality learning workshops where we brought together the LJM&E officers and the MNCH coordinators to self-assess data quality for their LGAs and present their findings to peers. Here they developed work plans for improving data quality in between workshops, and they also defined performance standards and milestones to clarify what they wanted to achieve. We introduced job aids to assess data quality based on the WHO toolkit. Monthly data quality summary reports were disseminated through the state M&E office. And ongoing engagement took place through WhatsApp to keep up on data quality checking activities. Overall, there was an emphasis on the partnership between the LGA M&E officer and the MNCH coordinator, and there was an intentional practice of providing constructive feedback. Briefly, in terms of results, we found that 14 of the MNH priority facility-based indicators could be found in the facility registers, and that 12 of these indicators were reported by the facilities for monitoring services that every woman and her newborn should receive. This indicated good potential for monitoring priority indicators. On the right-hand side, you can see that the indicators available in the facility reports included contact indicators, which tell us about when women are visiting facilities, and the content of care indicators, which tell us about the specific services they receive during those visits, and the main denominators that are used for calculating indicator coverage. When comparing the early and intensive periods for strengthening routine data, we found that the data quality improved for 7 out of 9 metrics, even for completeness of reporting, which was already meeting the criteria for completeness during the early period. The consistency over time did not improve, and this is mainly due to much higher uptake in MNH services in recent years compared to the previous 3 years. There were differences in data quality by indicator type. So contact indicators, which already had a relatively higher data quality at baseline, didn't change as much compared to commodity-related indicators such as anemia testing and iron folic acid supplementation. Bringing this all together, I wanted to highlight a few key messages from this work. First, in Gombe, as in other settings, routine health information systems are set up and can monitor priority facility-based indicators for decision-making, and there are opportunities to improve the measurement, completeness, and consistency of routine data. Further, coordinated actions are needed at multiple levels of the health system to achieve and maintain routine data. And I'll go into 3 of these actions in turn. One recommended action that can be taken at the state and national level is to maximize the reporting and specificity of documented data. And here I'm going to cite 2 examples. As I mentioned before, there are 2 priority indicators that are collected in the registers but not reported in the monthly summary report forms. And these are the active management of 3rd stage of labor and essential newborn care. This could be because the indicators became a priority after the tools were designed, but there is still an opportunity to use them for monitoring as they are already being collected. On the right-hand side, we see that there are priority indicators that are being collected in the registers, but the degree of specificity could be improved for effective monitoring. So for example, gestational age is collected as a preterm birth yes or no binary value. Also, birth weight is captured only for live births, and only as less than 2,500 grams or greater than or equal to 2,500 grams. If we improve the data capture of birth weight, this could help in monitoring the complications associated with small and sick newborns. Another recommended action that could be taken at the national and state levels is ensuring high-quality implementation of electronic health information systems such as DHIS2. Having access to DHIS2 means that we have access to data faster and with lots of visualizations that help us more readily understand what is happening in our facilities and districts. But some of the challenges that we see in DHIS2 are unrelated to what the data facilities are collecting and reporting, but really reflect poor digitization of facility data. So for example, master facility lists are not always up to date to reflect the active facilities offering services. or there are active facilities that are still linked to inactive wards, or there are inactive and duplicate facilities or data elements. Or importantly, DHIS2 may not distinguish between zero or missing values. And this is particularly important when deciding corrective action, because facilities that are offering services but no one has come to the facility require different solutions than facilities who are not reporting but have been providing services to families in Gombe. So it's important that we pay attention to how facility data are digitalized in electronic information systems. Lastly, when we reflect on the activities that were undertaken to improve the routine data quality, at all levels of the health system, it is important to promote a positive culture of information use by addressing the organizational, technical, and behavioral aspects of data quality checking. For example, for organizational factors, there was an emphasis on the partnership and joint responsibility of M&E officers and MNCH coordinators for data quality in their LGA. And there was dedicated time and space for self-assessment and peer review of findings. For technical factors, there were data quality checking job aids that were introduced, which promoted an in-depth knowledge of the data quality metrics and really enhanced their vocabulary to discuss the aspects of data quality with facilities. And for behavioral factors, there were skill sessions and deliberate practice on providing constructive and positive feedback. I hope that this presentation has been useful in highlighting the key results of the activities in strengthening routine data quality in Gombe State. And I look forward to reflecting on this further and discussing with you during our face-to-face conference call next week. Thank you so much for your time and for listening.